Good morning, everybody, and welcome to today's Changing the Way We Work Community of Practice for Ontario Family Physicians. I'm Eleanor Colledge. I'm a family physician. I work in East Toronto. I'm also the CPD Program Director at the Department of Community and Family Medicine at U of T. I'm thrilled that we can continue to bring you these sessions in partnership with the OCFP, and I'm going to turn things over now to our president, Dr. Jobin Varughese, to introduce the session.
Thank you very much. And we're looking forward to a really strong session. We have a returner in Gerald and a great session by Dr. Marisco. Next slide, please. Just a reminder that, next slide, please. Just a reminder that these program is a MAPRO accredited program. And if you do happen to miss it or miss part of it and want to go back, feel free to catch the recordings, and you can do the MAPRO credits after the fact as well. It's just a quick couple of questions. Next slide. So I'll just jump into our land acknowledgement. We acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognizes that many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respects that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And Eleanor, I'll hand it back to you for a reflection.
Thanks very much, Jobin. So I thought today, as in the second half of the session, we are going to be talking about nutrition, that I would reflect on that with respect to the Indigenous people. And first of all, I mean, what I found out recently is that sadly, historically, some of the recommendations that come in our very commonly known Canada Food Guide actually may have been based on nutritional experiments on children and adults in the 1940s and 50s in residential schools and across Canada. Nutritional experiments that were conducted without consent and sometimes, for example, using ingredients that hadn't been approved. So that's a piece of history that I wasn't familiar with, and certainly one that is good to keep in mind in terms of just reflecting on where things that we have today come from sometimes. Also, I think we all know that with removing children from their communities, and putting them in residential schools, they were taken away from their traditional diet and usual cultural practices associated with food. And I think we're familiar with some of the impact that's had on Indigenous people. I know, for example, when I worked briefly up north in Northern Ontario, when the elders would go in to the bush in the summer, we had to remind them all to stop their diabetic medications or they would become hypoglycemic when they started eating their more traditional diet. So I show on this slide here today's food guide, which has been translated into Cree, and it's nice to see that efforts to address things like language barriers are being done. But there are still a lot of questions about whether a food guide such as this is able to be put into place or is applicable to Indigenous people, especially who may be living in communities where it's quite hard to either afford or access a lot of fruits and vegetables that are fresh. So I think it's important to consider when we're talking with our Indigenous patients about nutrition, where they may be from the past and from the present in terms of their reality. I also wanted to just briefly talk about some of the positive things that are happening with respect to nutrition in particularly northern communities. This other picture here shows some greenhouses and something that's being experimented with by Indigenous groups in communities to bring fresh fruits and vegetables into their communities more easily. So that's one thing that's happening, and hopefully will enable them to also grow some of their traditional crops that they would choose to eat. And then also because I know outside of our work, it's sometimes hard to know how to make an impact or help in problems that seem large or insurmountable. I just wanted to remind people that often funding is a barrier to many of these projects getting off the ground. And there are lots of ways in which, if you ever felt like making a donation to projects, I put up a little slide here about one that's run by Kinvia, but there are lots of others out there, so something to consider. Next slide, please. So just a thank you to our scientific planning committee who make these things run smoothly, and a reminder, as Jobin already pointed out, that this is a series and all of our sessions are posted online, so you can review ones from the past. Next slide, please. I'd now like to introduce our panelists and have them speak to their conflicts of interest. I'll turn things over to Dr. Gerald Evans.
Thanks very much, Eleanor, and thanks for the invitation to present this morning. The major conflict of interest I have is that I'm now the clinical lead for Ontario Health in infectious diseases, and I chair a committee for Ontario Health, and I receive a modest amount of remuneration from them. And of course, we as speakers oftentimes get some financial gain from doing these talks. So those are the only conflicts that I have at the moment. And for people who don't know me, I'm in Kingston. I'm a professor of medicine at Queen's University and the medical director of infection prevention and control at Kingston Health Sciences Centre.
Great, thanks very much, Gerald. Turn things over to Dr. Mary Scow.
Hi, everyone. So currently I don't have any grants or research support or financial conflicts of interest to declare. Today, I will be mentioning a website that I created where I house the nutrition guides that I use with my patients and share with others. But I wanted to note that I receive no funding to create this website, no royalties, and no remuneration.
Thanks very much, Dr. Scow. And I'll turn things over to Dr. Dan Wachowski.
Hi, morning, everybody. Daniel Wachowski. I'm an Associate Chief Medical Officer of Health and Ministry, and still nothing to declare, which is great.
We're just waiting for the day, Dan. Next slide, please. Dr. Jobin.
Hi there, Dr. Jobin Varughese. I'm the president of the Ontario College of Family Physicians, where I do receive a stipend, and I'm the interim assistant dean of primary care education at TMU School of Medicine.
Thanks very much, Jobin. And I've already introduced myself. I do receive an honoraria from the OCFP, also for some work that I do for the Foundation for Medical Practice and Education, and also for my CPD work at the University of Toronto. Next slide, please. So just a reminder, if you're new to this group, how to participate, please put your questions into the Q&A. And if you see a question that you'd like answered, remember to upvote it so that I can prioritize those ones with the most votes. And then, of course, please use your chat to share. Use the chat to share your thoughts, your resources, basically to network with your colleagues. But just a reminder, please post your questions in the Q&A so that I can grab them there. Next slide, please. So just in terms of today, we're going to start with Dr. Evans, then we'll break for some questions. Dr. Evans has to leave at 8:30, so we'll be making sure that we cover all of his questions in that first section of question Q&A. And then I'll be turning things over to Dr. Scow, who's going to talk about nutrition. And then we'll plan to finish everything up by 9, the main content. And then if we have a lot of questions, then we'll continue to 9:15 as needed. Next slide, please. I think I'm turning it over to you, Gerald.
Yeah, thanks very much, Eleanor. So I'm just going to try and give a quick ID update for everyone as we're entering into the respiratory virus season. This is one of my favorite little cartoons from back in the pandemic days, just remembering that, vaccines are important, and we're going to talk a little bit more about that as we go along. Next slide, please. So this is just the latest that we have in the way of respiratory virus activity projections for Ontario. We have experienced a bit of a rise in COVID in terms of test positivity, which now seems to be plateauing and in fact may even be declining. Influenza A has remained at interseasonal levels through much of the early part of the fall. At the moment, the projections based on test positivity show a flattened curve, but I'm going to suggest to you that that may be a little bit off just by some of the information that we've been gathering. And RSV is just about prepared to make its usual entry into the season, which is oftentimes in November. Remembering that RSV early in the early winter or the late fall is oftentimes a pediatric infection. And then we start to see RSV in adults as the winter progresses. Next slide, please. So if you want to look at it in comparison to previous years, this is another graph that we have from the respiratory virus tool that's out there. You can see that COVID looks like it's peaked and it's dropping. RSV is on the increase, and that would fit with what we've seen in previous years. And influenza A, which is always a little bit unpredictable, looks flat at the moment, but I'm going to again suggest that it's going up. Next slide, please. This is just a little bit based on prediction and past on hospitalizations by age. Pediatrics to the left. In the middle are your young and middle-aged adults, and on the right are adults over age 65. And so you can see the only group that we're expecting to see some hospitalization increases at the moment, at least, is pediatrics, and that's related to RSV activity, with influenza remaining low as long as it doesn't show up early. Next slide, please. So this is just a little bit of a trending graph that I've made based on previous years. And this is a graph that goes back to the first part of 2024. So there's basically almost 2 years worth of data on this. And you can see COVID in red, influenza in blue, RSV in green, with a lot of predictability about what's happening. But that sharp rise you're seeing in influenza activity right now is actually based on the fact that we are beginning to see in the month of October, although not completely unusual, but the number of infections we're seeing is starting to rise. And in some jurisdictions around the world, including Japan, which I'm going to very briefly talk about, have actually declared a significant epidemic of influenza with a very early onset and principally affecting mostly young people. So I think we need to be prepared for that. But the interesting thing you can see here is as the blue goes up, the red goes down. We think that may be a viral interference signal that when influenza hits, it tends to suppress through a mechanism called viral interference, COVID. So if there's a silver lining to an early flu season this year, it may be that COVID, that wave that we've begun to see now through September, may be attenuated and continue to plateau. Next slide, please. This is just the Ontario 14-day moving average of test positivity. And it was just to point out, I really like this graph because it shows you that between about mid-February all the way till about mid-August, we were in extraordinarily low levels of COVID activity as measured by test positivity of people who were being tested. Now, test volumes were down, but in a general sense, the sample within the general population is reasonable. So this is encouraging, and it's suggesting, at least from a virology evolution process, that COVID may be beginning to gather the aspects that most human coronaviruses have, which is to be a seasonal virus. And you can see here that the test positivity looks like it may have peaked just below 10% and maybe actually be dropping. Next slide, please. This is just a little graph that, again, is on the respiratory virus tool that you can access. And this is outbreaks in the province of Ontario in congregate settings. So this includes long-term care homes, hospitals, retirement homes, et cetera. And what you can see is with this test positivity increase actually did reflect itself in an increase in the number of outbreaks. But since that period through most of September, it now appears to be dropping. This data, unfortunately, is only up to date as of the end of September. And tomorrow there'll be a release, which will probably guide us at least into the month of October. Next slide, please. So what's driving all this is, of course, this virological evolution of SARS-CoV-2, the virus that causes COVID-19. And the current one that's driving everything is actually another recombinant vaccine. Some of you remember 2 years ago we had XBB. Well, now we have XFG, which is a recombinant of 2 Omicron subvariants, LF7 and LP8.1. And this really began a global emergence in the late spring, early summer. It has a small degree of growth advantage, although not at the level that I would expect that it's going to be a dramatic rise. There is some modest immune evasion compared to last year's dominant Omicron subvariants, which was JN1. The good news is it does not appear to cause new symptoms or more severe disease as a virus by itself. Having said that, many people who haven't had COVID for a number, maybe perhaps 1 or 2 years, or have not been vaccinated recently, may experience perhaps a more significant illness when they do get sick. This year's COVID vaccine, which is now available, is based on LP8.1. And so there is some suggestion that it will provide some reasonable protection because part of the recombinant XFG is in fact LP8.1. And a reminder that since the emergence of Omicron now we're at about 3.5 years ago, the home tests still work, but you have to do them daily for up to 3 days following the onset of symptoms to be sure that you actually have a negative test. So that's the way you have to do it. You can't rely on one test done on day 1 and another test done on day 2. Next slide, please. So this is just a little bit of the projections, and you can see that this XFG3, which is one of the current XFGs that we're monitoring, does show a projection that it's going to increase over time, and certainly at one point it will probably tend to dominate through the middle part and late part of the fall. Next slide, please. This is actually a really cool study, and I wanted to mention this as I get back into this idea of getting vaccinated. This is a VA study from the US, and it actually showed that and compared observationally people who had the COVID vaccine to people who didn't have the COVID vaccine. And the vast majority of subjects that were looked at in this study were actually sort of young or middle-aged adults who are reasonably healthy, some elderly people as well, obviously with the VA study. But what you can see here in the graph in the top left is emergency department visits. On the top right are hospitalizations. Bottom left are deaths, and then the bottom right one is a composite outcome. And when you compare vaccine recipients of the COVID vaccine to those who didn't, and these are all COVID-related phenomenon that they were looking for, there's a distinct decrease amongst those who are vaccine recipients. So COVID vaccination is still important. It does help to reduce the overall burden to the healthcare system. This would obviously have an impact as well, potentially on office visits to family physicians in people who get COVID. But it continues to show that COVID vaccination has an important effect. And this is a very large study that was just published in New England Journal of Medicine. So I think really it makes an argument that we should still be looking at annual COVID vaccines until we're sure that we've developed or gone into a potentially endemic phase of this illness, and it's adapted itself to not be as nasty as it was when it originally arose. Next slide, please. So a very quick update on measles. I know people still are paying attention to this, and we do worry about it a little. So next slide. So this is the Canadian-wide data as of the late part of September, and you can see that the largest burden of disease was in Ontario in terms of the number of cases, followed by Alberta. And we're up over 5,000 cases by the end of September when the last data came in. Next slide, please. Here in Ontario, you can see the distribution of cases around the province with a concentration mainly in the southwest, which probably had the largest burden. Where I am here in the southeast, the legacy Hastings Prince Edward County Public Health Unit had a small number of cases, but have not had a number of cases since, wow, way back in early 2025. Next slide, please. So you can see this epidemic curve here of measles with a real hit by the mid-spring, with a real diminishment in cases up to where we are now. And in fact, many of you may have noticed that, in fact, the Ontario measles outbreak was declared over. And I think that's certainly a reasonable declaration to make based on numbers. Having said that, the Americans are still experiencing large numbers. There is unfortunately not a good surveillance mechanism collecting this data and reporting it. But to give you an example, right now, although the Texas outbreak was declared over, Wisconsin, a state which borders right on Canada, has actually experienced a number of cases now popping up, particularly in areas where vaccination rates for measles are low. And just remember, measles is such a transmissible virus, it will find you if you're not vaccinated, even if you don't really have any risk factors. So I would still keep a diligent eye out. The good news is here in Canada, our vaccination rates for measles generally nationally across the board is about 92 to 93%. Next slide, please. And this, again, just to point out, in orange are the cases that were unimmunized. So yes, some people who are immunized can get measles. That's oftentimes related to age and the distance from the time of their most recent vaccination. And so still worthwhile when you're assessing patients to make sure that you have a reasonable vaccination history. The biggest problem that we have is if you were born before about, well, I guess when I put it, peg it, if you were born at a period when we were only giving one dose of measles vaccine, and that was prior to about the early 1990s. Some of those people may be worth getting a second dose into, just because of the fact that we've had an increase in cases. Next slide. So really, this is just to point out what I was saying before about the rise in influenza this year. It looks like it's probably going to be potentially early season. Japan has already declared a flu epidemic. And what they've been seeing is a lot of influenza cases, particularly in young people. They have over 4,000 hospitalized individuals. And a large proportion of those are actually individuals who are less than 14 years of age. That may suggest to us that it's an influenza B dominant season right now in Japan, because influenza B causes a more severe disease in younger people. But we don't know that yet because we're still collecting data on the isolates that have been out there. And it may in fact be an influenza A dominant season, and just with a lot of children affected. And remember that flu is one of those things that's nicely amplified in schools. Which is why during the early part of the COVID-19 pandemic, we closed schools. That's because it was based on modeling with influenza. And in fact, influenza, it was not an influenza pandemic, but rather a coronavirus pandemic. So again, those things don't always sort of map up. But I'll stop at that point and happy to answer any questions.
Great. Thanks very much, Gerald, for bringing us up to speed and giving us a heads up about where the flu epidemic or flu cases might be this year. A couple of questions, and actually, Dan, I'll get you to come on camera too, because I think some might end up coming your way. First of all, just in terms of treatment for COVID, there was a question here. Is 10 days of Paxlovid better than 5, given prolonged test positivity and rebound on Paxlovid 5 days?
Yeah, no, 5 days is fine. Be very careful about the concept that you may be shedding by the virtue of a lateral flow test. These are the home tests that people use because they're not actually necessarily an accurate marker. They actually pick up remnants of virus, so they may not actually be shedding live virus. So there's no advantage at the moment to taking 10 days of Paxlovid. 5 days should be the traditional prescription.
Great, thanks. And another question about treatment. Can you please give the new metformin dosing in writing for COVID treatment?
Oh, that's the one where there's some, observational data that people take metformin have a lower incidence of long COVID. It's a great question to ask me because I've never used it, and I do not know what the current dose is that's recommended from those observational studies I've done. I've seen. I would have to hazard a guess, and that's probably not a good thing to do. So I just have to look at the clinical trials well, they weren't really clinical trials. They were observational studies looking at those who received metformin versus not. I think there might have been a couple of very small trials that looked at metformin as an attempt. I don't know if Dan knows that what the metformin dose should be. Probably shouldn't be a big one.
I think in the Together trial, it was 750 twice a day. I'd have to double check, but I would follow the CAN-PCC guidelines on this as just a plug for them, because they're doing fantastic work on post-COVID condition, everything to look for. So that's where I go if I have questions. So maybe don't quote me on the number. I'm just trying to remember, but go there, and I'm sure they have all the information on that on their website.
Great, thanks. Actually, while you're on unmute, Dan, a question here about how can we get COVID tests?
Yeah, no. So for healthcare providers, you can still order rapid COVID. I assume they mean rapid tests in the question, but I can talk about both. So rapid tests are still available through the Supply Ontario portal. So you just have to sign up for the program and register on it, but it's pretty quick and easy. And I want another plug here. You can order more than just rapid COVID test there. You can order all of your swabs there. You can order PPE through that. You can order cleaning products through that. You can order your vaccine supplies like syringes and needles. They are all available through the Supply Ontario website at no cost to healthcare providers. So please go use that.
Yeah, that sounds like a good plug, and nice to have it all in one place. There's another question here actually about testing for influenza and RSV in the community. I assume that would primarily be happening in clinics if it was appropriate.
Yeah, I mean, a lot of places are doing multiplex testing, although there's now, we do 8 viruses here, but many places do at least influenza, RSV, and COVID now during the respiratory season. So you will have to access that through a clinic or an office. Public health does monitor through a sort of national program called Flu Watch, which Ontario is part of. And as soon as we get the large rise in cases, oftentimes we reduce the amount of testing that's coming from the community because we know that seasonal flu has arrived. And that further testing doesn't really necessarily help to increase that. But if you pop into emergency departments and places like that, they will continue to do testing and at least do influenza, RSV, and COVID.
Great, thanks, Dr. Evans. Another question here, can a person younger than age 65 get the RSV vaccine and pay out of pocket off-label, i.e. age 40s if they have asthma?
The answer is yes. You can always pay out of your own pocket for a vaccine, and then you just have to get somebody to administer it to you. You know, the evidence that we have about RSV is very impressive, but it's more impressive in older age groups up to a point. And then at one point, you're at such an age that the advantage of getting the RSV vaccine begins to diminish. It's rather along the same lines that we see with Shingrix vaccine. So Shingrix has an age range in it, and we don't give it beyond that age range because the likelihood that you're going to have a meaningful impact on reducing disease and the economics of whatever happens in people who get shingles afterwards is not always there. But you can always get these vaccines at many different at other ages. It's a commercial license which has been granted to the vaccine. But I think you know, someone with underlying asthma, asthma or COPD for that matter, the virus that actually causes more of the problems in that group in terms of exacerbations are actually rhinoviruses, the one that causes the common cold. And there was a good study that came out of Britain recently that showed actually rhinoviruses are number 3 behind influenza and RSV when it comes to serious illnesses that end up in the ICU. So I'm not arguing against that person if they make an individual decision in discussion with their own physician about getting the RSV vaccine, but it is pretty pricey. I think it's upwards of over $200.
Great, thanks very much for clarifying that. Now, you did touch on this in your presentation in terms of the fact that COVID vaccine is still effective in terms of decreasing hospitalization and illness. There was a question regarding percent effectiveness. I don't know if we have percent effectiveness of the vaccine against infection and duration. I guess question around duration and whether it impacts on that as well.
Yeah, the most of the data is looking at endpoints, so that's what that observational study from the VA showed. If you look back at the older data from the vaccine, when the vaccines were first introduced, there is a fairly good evidence that viral shedding is reduced in vaccine recipients compared to those who are not vaccinated. Now, that was done in a naive population, not people who had COVID before. The infectivity of the virus is reduced in vaccine recipients. So in essence, some of the benefits of being vaccinated against COVID also would result in a reduction in transmission based on biological endpoints, so surrogate endpoints about that happening after vaccine recipients. But the duration of illness, I think, is based, there's a lot of probably some reasonable evidence that hybrid immunity, which comes from both having had COVID as well as being vaccinated, that the duration and severity of illness is dramatically reduced in those individuals.
Great, thanks very much. A question in the chat, and also I see in the Q&A, just could you remind us, Dan, what's available on the public supply portal? And we will find that portal link and post it as soon as we can.
Yeah, I should have had it ready to go. Sorry, Eleanor. I can share it afterwards. Yeah, so it's broadly like most things that you would need for the respiratory season. So it includes obviously PPE, like that's the initial function of the portal was your masks, but that includes then gowns and gloves and everything else PPE. It includes like disinfectant products. You know, it might not have everything that you use, just want to be clear up front, but it will have a number of things like hand sanitizers and other disinfectants. It includes vaccine supplies like syringes and needles and alcohol swabs, and then includes rapid antigen testing and other testing swabs available. So they can all be ordered through that portal.
Great, thanks very much, Dan. Question here, is the current flu vaccine effective for what's expected this year in Canada? Do we have that data yet?
So the answer is we don't have the data. Here's the part that I'm going to share with my colleagues who are on this call, but please don't go around like scaring people. There's some emerging evidence at the end of the Southern Hemisphere flu season that there was a significant change in the clade. So when you look at influenza A, H3N2, there's various clades. And that looks like it may produce an issue where the current vaccine strain for influenza A, H3N2 may not be a perfect match to what could circulate this year. And some people have speculated that that may be driving what looks like an early rise in influenza this season. It's really important, I think, not to sort of tell people, oh, don't get the vaccine, because in fact, the H1N1 component is almost perfectly matched from what we were expecting. And influenza B, which is an important virus, especially in younger people, in children and stuff like that, that's a good match too. The Victoria lineage strain is fine. So they're, missing one component. could be an issue, but who knows if it's going to be an influenza B dominant season or an H1N1 dominant season, in which case this change in H3N2 may not actually be significant. But again, it's speculative based on some analysis of the genomic changes that are seen at the end of the Southern Hemisphere's influenza season. So I still push to get flu shots. This is where I got my flu shot this week. This is where I got my COVID shot this week, which is an answer to some of the questions people pose, which is, should I get my shot? Yeah, sure you could. Now, I know I'm old because I got gray hair, but having said that, I used to get my flu shot regularly when I was a younger fellow. So it's really important as in healthcare workers to get your vaccines. We got to keep going while all this stuff is happening, take care of our patients and stuff.
Great, thanks very much. I'm going to turn things over just to measles because there's a question here. Based on current measles trends, is the current advice to get MMR early for babies from 6 months or still wait until 12?
Yeah, no, I think, there was a lot of concern about trying to vaccinate children under the age of 1 year when we were seeing this huge rise in cases. I don't think that is there anymore. As was mentioned, the outbreak here in Ontario has been declared over. So I think we should continue to just do our vaccinations as currently outlined in the immunization schedule for the province of Ontario and under the NACI recommendations, which is 1 year. I think if there's a potential that someone's going to travel, that's a discussion to have with your individual practitioner. We do have recommendations for giving measles vaccine if you're intending to take a child who's maybe 6 or 8 months old, maybe to a jurisdiction where there is a lot of measles cases. But that's an individual consideration, but there's no general recommendation right now to immunize children before the age of 1.
Great, thanks very much. So 2 last questions, and then if you have a moment to answer any in the written, then that would be terrific, but we also know that you have to jump off soon. So just around COVID vaccinations, what ages should be getting the COVID booster? This is a quick one for you.
Yeah, of course, we don't call them boosters anymore because the vaccine's being changed each year as it matches up with what we know to be or expect to be the prevalent subvariant or variant of SARS-CoV-2 that's going around. There is still a recommendation that children over 5 can get the vaccine. I think, again, that becomes a little bit of an individual decision. Children do seem to tolerate COVID reasonably well. We're not seeing an increased mortality or morbidity signal as much. The primary determinant of bad things with COVID is still age. And when I say that, I'm talking about advanced age, as in this, not children. So yeah, I think childhood vaccination against COVID is not a bad idea, but I think everyone needs to sort of take that as an individual decision, maybe. As a parent, I don't think there's a compulsion to do it. And, the one thing we know about COVID vaccines as well, should be really mentioned. It's the only really effective strategy we have. And I know we were talking about metformin earlier, that actually shows a reduction in long COVID incidence as previous vaccination. So vaccination is still important. In children, do you see long COVID? There are some signals, but it's much smaller in terms of percentage compared to adults and compared to adults who have had a number of infections where there may be an additive effect. And the whole long COVID thing is almost certainly related to what we're seeing now, emerging studies on the genetics of people who do suffer prolonged symptoms following any infection, and that there does seem to be a bit of a genetic signal in how those people end up with these prolonged symptoms following anything, flu, COVID, EBV, you name it.
Great. Thanks very much, Dr. Evans, for speaking today. And we're going to turn things over now to Dr. Sko. But there are a few questions in the chat. If you're able to get to them before, sorry, in the Q&A, if you're able to get them before you leave, terrific. Otherwise, we'll get them next time. And now let me turn things over to Dr. Sko.
All right. Good morning, everyone. I'll just wait for the slides.
They're coming. Here we go.
All right. Such a pleasure and honor to be speaking for you today. I'm really excited to share this content. Slide, please. Slide, please. Yes, thank you. I want to begin with a multiple choice question. If you could only make one recommendation to your patients to lower their systolic blood pressure, which recommendation do you think will lower their blood pressure the most according to data from meta-analyses of randomized controlled trials? Would you tell them to decrease their sodium, increase their potassium, adopt the DASH diet, or eat 4 tablespoons of ground flaxseed per day? I'll give you a second to think about it. You want to shout an answer in the chat, that's welcome as well. And slide, let's look at the answer. So in fact, the flaxseed, the thing that you wouldn't think would have the biggest effect, according to data, actually has a pretty profound effect on systolic blood pressure. Slide, please. There are probably many reasons why flax seeds can influence blood pressure, but one of the most important reasons is the omega-3 fatty acids that they contain. Slide, please. And in order to understand how omega-3 fatty acids influence blood pressure, I want to tell you a little story that will illustrate how you literally are what you eat. Slide, please. And in order to illustrate that, I want you to think about the 37.2 trillion cells that you are comprised of. And specifically, I want you to think about the membrane that encircles every one of those cells. Slide, please. In high school biology, we of course all learned that every cell in the body is surrounded by a phospholipid bilayer. Slide. And that phospholipid bilayer is comprised of phospholipids. And those phospholipids are comprised of a phosphate head and 2 fatty acid tails. Now, what are those fatty acid tails made of? Slide. They're made of things like omega-3 fatty acids and omega-6 fatty acids. Slide. Research shows that if you eat more omega-3 fatty acids, every single cell in your body will be surrounded by more omega-3 fatty acids. Slide. Now, omega-3s are very unique and very special. Part of the reason is because of their chemical structure. If you look here at this omega-3 fatty acids, you can see it has a lot of double bonds. All of those double bonds give that fatty acid this very this hydrocarbon chain with a lot of kinks in it. Slide. This is in contrast to other types of fat, like saturated fat, which, as the name implies, has a hydrocarbon at every has a hydrogen at every carbon valence. And as a result, the hydrocarbon chains that saturated fats are comprised of are very straight and linear. This allows them to line up neatly. This is why saturated fats like butter are solid at room temperature. Slide. But if you compare that to the omega-3s have this awkward structure. They can't arrange themselves neatly. As a result, when you have more of these omega-3s in your cell membrane, you end up having this more fluid and flexible cell membrane because they just can't stack up in the same way that other fats can. Slide. So we think that what's happening is the omega-3 fatty acids are leading to a more fluid and flexible cell membrane, which is ultimately decreasing arterial stiffness and thus impacting blood pressure. Slide. So if you think about it, based on this mechanism, flax seeds essentially are nature's amlodipine or nature's calcium channel blocker. Slide. And if you do a head-to-head comparison, you can see that for some patients, 4 tablespoons of milled or ground flaxseed per day could lower systolic blood pressure as much as a single first-line blood pressure medication. Of course, you can give people multiple medications, but if you just do a head-to-head comparison of flax seeds and one single medication, they could be equivalent for some patients, according to the data. Slide. Other sources of omega-3s, like chia seeds, have also been shown to lower systolic blood pressure. Slide. However, I want to note that not all sources of omega-3 fatty acids are guaranteed to have this magnitude of effect. We know that flaxseed oil has some modest benefits, but not to the same extent as the seeds themselves. Fatty fish have some observational trials behind them because we know fatty fish are a source of omega-3 fatty acids, but we don't have the same level and rigorous amount of data. And interestingly, omega-3 supplements have not been shown to have this effect. This is probably because if you think back to that chemical molecule, that chemical structure, all of those double bonds make omega-3 fatty acids very reactive and very prone to oxidation. So the problem with the supplements is an inherent problem or struggle or challenge with the omega-3 fatty acid molecule itself. It's just very, very prone to oxidation. And there are studies that show that it doesn't matter what price you pay for your supplement, what country it comes from, what the standards of qualities of manufacturing are. Because of the inherent propensity for oxidation, these supplements are not always going to deliver the guaranteed effect when you take them. Slide. You can't talk about blood pressure without talking about salt or sodium, so we will touch on this for a moment. Slide. In order to illustrate how tricky the sodium situation is, I want you to imagine you're comparing the sodium levels in these 3 foods. This is real data from these company websites. Say you're deciding between a banana pecan muffin from Tim Hortons, an extra large slice of pepperoni pizza from Pizza Pizza, and a 6-inch tuna sub from Subway. Which do you think has the most sodium? If anybody wants to shout out an answer in the chat, feel free to do so. I'll give you all a moment to think about it. Got some votes for tuna sub. Let's look at the answer. So in fact, the muffin, the thing that you would not expect to actually have very much salt in it, actually has more sodium than a slice of pepperoni pizza. So this just illustrates how tricky this sodium situation can be. Slide, please. For very motivated patients, I will occasionally use this online sodium calculator. So this is a validated tool developed in Ontario that can estimate sodium intakes based on a quick little survey. I know how valid this tool is because I was in the validation study myself, and they did 24-hour urine sodium collection to ensure that their tool actually reliably predicted sodium intake. So for those very resourceful, very motivated patients, I will occasionally use this tool. Slide. But I don't want to spend too much time speaking about sodium because I find that that's the nutrient we always think about when we talk about blood pressure. But, slide, the forgotten nutrient and the other half of the blood pressure equation really is potassium. So that's where I want to focus our efforts today. Slide. Blood pressure regulation partly takes place at the level of the distal convoluted tubule, and it's controlled by the levels of sodium and potassium at that point in the nephron. Slide. Blood pressure regulation requires a balance of these two ions. Now, historically, humans ate 7 times more potassium than sodium. Today, potassium. So our relative intakes of these two very important nutrients that control blood pressure has completely switched. Slide. We know that what happens is when our blood pressure is low, our sodium chloride cotransporter at the distal convoluted tubule will reabsorb sodium to increase our blood pressure. Slide. But what also happens is when our potassium intakes are low, that transporter will also reabsorb sodium to increase blood pressure. Slide. And when our potassium intakes are low and our sodium intakes are high, that transporter reabsorbs even more sodium to increase blood pressure to an even greater degree. Slide. This is a beautiful study. Over 100,000 people in 18 countries published in the New England Journal. And what they concluded is that when it comes to blood pressure, the only thing worse than a high sodium diet is a high sodium diet that is also low in potassium. Slide. And that's exactly what we are dealing with. Canadians eat far too much sodium and not enough potassium. Slide. This is a meta-analysis of 21 randomized controlled trials that showed that 3,500 milligrams of potassium per day can lower systolic blood pressure by about 7 millimeters of mercury. Slide. And to put that into perspective, that's not a huge therapeutic super physiologic dose. That's actually pretty close to the daily recommendation for potassium intakes for everyone, just for general health. Slide. So when I talk to my patients about blood pressure, I of course want to educate them about dietary sodium, and I show them this guide, which illustrates the top contributors of sodium to the Canadian diet. But at the same time, I don't just want to take things away from them. I want to give them options. So I also tell them the more potassium you eat, the lower your blood pressure will be. And here are the richest dietary sources of potassium. And the more of these foods you eat, the lower your blood pressure will be. So then I'm giving them options and hopefully encouraging them to add something new to their diet that can also be added to any diet, irrespective of what cultural or preferences that anybody has. Slide. Now, you might be thinking a lot of our blood pressure patients are on ACEs and ARBs, where there's a theoretical risk of hyperkalemia. This is a study where they fed those patients a very high potassium diet and showed that eating 10 servings of fruits and vegetables per day, rich in potassium, didn't actually increase risk of hyperkalemia in patients on these medications. So it is safe to make this recommendation to these patients. Slide. And another population where we have to be mindful of potassium intakes is our chronic kidney disease patients. Although the guidelines say that if the patient doesn't already have hyperkalemia, you don't actually have to be so judicious with limiting potassium intakes. It's really going to depend on whether they have hyperkalemia or not. So it will depend on the patient effectively in a chronic kidney disease setting. Slide. So far, we've talked just about 3 different diet and lifestyle approaches to lowering blood pressure, but it really doesn't end here. Slide. There are so many different things that we can offer our patients. Slide. So when I talk to patients about blood pressure, I want to illustrate for them everything that they can do, every food that they could eat or remove, and every lifestyle intervention that they could apply. Because ultimately, we want to encourage them to do as many different things as possible. Slide. Because in the same way that when we choose blood pressure medications, we select them based on the fact that different medications target different aspects of the blood pressure regulatory mechanisms, different dietary and lifestyle interventions also target different aspects of the blood pressure regulatory mechanisms. So if patients utilize multiple different strategies, they're hopefully going to have synergistic or at least additive benefits by targeting those different parts of blood pressure control. Slide. So to recap, flax seeds and chia seeds have potent blood pressure lowering capabilities. Increasing dietary potassium intakes is an easy, safe, and effective way to lower blood pressure. And finally, we want to offer our patients as many different diet and lifestyle interventions as possible so as to capitalize on all of the different mechanisms for lowering blood pressure. Slide. We'll change gears slightly and talk about diabetes. Slide. And I have a case for you. Let's imagine you have a 51-year-old male. His A1C is 6%, and you diagnose him with prediabetes and says, I want to prevent diabetes. What do you tell him is more effective? Should he adopt the 1992 American Food Guide pyramid and exercise for 150 minutes per week, or should you start him on metformin? Slide. Of course, the answer is diet. Slide. This is a beautiful study from 2002, randomized controlled trial that showed that lifestyle interventions are more effective than medications for preventing diabetes. Slide. And I want to emphasize, it's the old food guide, the one where bread, cereal, rice, and pasta are the foundation of the diet. So it just shows that you don't have to be extremely restrictive in order to make a difference. Slide. Now, of course, the patient comes back, he's 63. His A1C has climbed to 6.5. You diagnose him with diabetes, and he asks you, can I reverse my diabetes? What do you tell him? Yes, you can, or it's too late. Slide. Of course, the answer is yes, you can. Slide. This is research that showed that when a low carbohydrate diet is initiated within the first year of a type 2 diabetes diagnosis, that can enable the remission of the diabetes diagnosis in 70% of patients. Slide. And I want to mention, low carb diets mean many different things to different people, but in this case, it was 130 grams of carbohydrates per day, which really works out to being a half of a cup of oatmeal for breakfast, half of a cup of quinoa for lunch, an apple for a snack, and a whole cup of pasta at dinner. So it's not even as restrictive as you might imagine. Slide. Whenever I have a patient whose A1C is above target, the first thing I want to understand is what is causing that blood sugar level to be elevated. There's some input that's leading to that outcome. So I use this guide. I just say, these are foods that raise blood sugar. Are any of these foods part of your daily or weekly diet? Slide. But of course, the patient is going to come, their A1C has climbed again, and they're going to say, I can't cut carbs. And can you blame them? They're going to say, isn't there anything else? Slide. And of course there is. My message today isn't to say that we should put all diabetics on low-carb diets. Cutting carbs is the most obvious way to lower blood sugar levels, but it is not the only way. Slide. The framework that I use to talk about strategies for mitigating blood sugar spikes roughly follows the 5 W's. Slide. So first, we have to talk about what type of carbs are being eaten. Slide. And the best guide to carb quality is the glycemic index, which ranks all foods based on their ability to increase blood sugar levels. It was, of course, invented at the University of Toronto. Slide. And here's a picture of me with the inventor of the glycemic index. He was on my thesis committee. Slide. And this is a great guide provided by the Canadian Diabetes Association, which really categorizes all foods into one of 3 categories: low, medium, or high glycemic index. And what I usually tell patients is your low and medium GI foods are foods that you can eat as dietary staples, and your high GI foods are foods you just want to be mindful of. Slide. The glycemic index is interesting because it gives us these comparisons and it gives us choices so we can understand the relative blood sugar raising potential of different options, whether it's bread. Slide. Different types of grains. Couscous is a high glycemic index grain. Barley is the lowest glycemic index grain. Slide. And when you compare different types of rice, it's fascinating how broad the glycemic index spectrum is when you look at all the different types of rice, with parboiled rice being the lowest GI and sticky rice being the highest. Slide. And one of my favorite fun facts is that the glycemic index of pasta varies depending on the shape. Not necessarily something I talk about with patients on a regular basis, but a fun fact to be aware of. Slide. But fruit is something that comes up very frequently. Patients are very confused about fruits and which ones they can eat and which ones they can, and if all fruits raise their blood sugar. And the glycemic index is what gives us clarity on this topic, because you can illustrate for patients that some fruits raise blood sugar more than others, and which ones do, and which ones do they need to be mindful of, and which ones can they actually enjoy more often. Slide. Next, who the carbs are eaten with matters. Slide. Anytime you combine protein with your carbs, you're going to lower the blood sugar spike. Slide. And by that token, I'm not recommending this, but if you put cheese on your macaroni, the protein and the fat in that cheese is going to slow down that blood sugar spike. Slide. How the carbs are being eaten also matters. Slide. I love this study. What they did is they took people and they fed them the same foods, but in different orders. So they fed them carbohydrates in the form of rice, protein in the form of chicken, and vegetables in the form of bok choy. And first, they fed them the carbs first, because that's what we all do, right? You go to the restaurant, there's the bread basket on the table, everybody eats carbs first. But that's, of course, the worst thing you can do. That raises blood sugar the most. But if you just combine the foods together, slide, and eat them all at the same time, mixed up like in a stir fry, you get a 26% reduction in the peak blood sugar spike. But you can do even better, slide. If you eat the vegetables first, followed by the protein and the carbs mixed together, you get a 36% reduction in the blood sugar spike. Slide. Slide. If you eat the protein first, followed by the vegetables and the carbs, then you get a 41% decrease in the blood sugar spike. And if you eat the vegetables first, then the protein, then the carbs, you can reduce that blood sugar spike by 42%. And it's the same foods, just in a different order. Slide. When the carbs are eaten is also very crucial. Slide. The same carbohydrates at lunch produce a significantly smaller blood sugar spike compared to the same carbohydrates at dinner. All we've changed is the time of day. It's the exact same food, different time of day, totally different magnitude of blood sugar spike. Slide. And this is because all of our hormones follow circadian rhythm. And there's certain times of day when certain hormones want to be high and other hormones want to be low. And if we capitalize on this, we can significantly mitigate the effects of our diet. Slide. This is a study where they took diabetics whose A1Cs were out of control. They put them on a time-restricted protocol where they ate all their foods between 8 a.m. and 6 p.m., and they fasted for 14 hours overnight. And just by applying that time restriction, they were able to decrease their A1C by 1.54%. If you compare that to metformin, it on average lowers A1C by 1.38. So just restricting that time of eating interval can have a big effect. But of course, your patient is going to come and they're going to say, well, I work till 8 p.m. or I work till 10 p.m. so I can't do this. But this is what I show them. Slide. This is a study where they fed a 1,400 calorie diet, which, by the way, is a little too much calorie restriction than I would recommend, but irrespective, that's what the study did. And on one hand, they had patients eating most of their calories at breakfast, some at lunch, and very few calories at dinner. And they showed that when you ate most of your calories at breakfast, you lost twice as much weight compared to the people who ate very few calories at breakfast, some at lunch, and most of their calories at dinner. So it shows same amount of calories, but distributed differently throughout the day leads to a totally different outcome. Slide. Where you are eating also matters. Slide. Of course, we want to encourage patients to eat at home as much as possible. Slide. And finally, we always have to remember the why. Food choices are driven by social, cultural, economic, and emotional factors. There's so much going into this. It's not always just science and planning. Slide. This is what I love to show my patients, is just what are all these strategies? And I find this is very, very well received by patients. Slide. So to recap, following the 1992 Food Guide Pyramid and exercise can prevent diabetes more effectively than medications. Low-carb diets can reverse diabetes in 70% of patients, and there's many different ways that we can mitigate the blood sugar spikes that are caused by carbohydrates. Slide. Very quickly, we're going to talk about nutrition and cholesterol. Slide. So the wisdom was that if you eat saturated fat, it raises your LDL or bad cholesterol. Slide. But in recent years, there's been a lot of controversy around this because of studies like this, which showed that even though saturated fat raises cholesterol, it doesn't actually increase your risk for dying from cardiovascular disease. Slide. But then other studies like the 2020 Cochrane Review said, sure, saturated fat has no effect on mortality, but they did show that saturated fat intakes do impact cardiovascular events. So I do think it's still worth talking about saturated fat with patients. Slide. But again, it's not just a matter of teaching patients about the foods that raise their LDL or bad cholesterol, slide. We also want to educate them about the foods that, when added to the diet, can lower cholesterol, slide. And there are many foods that, when added to the diet, can lower LDL cholesterol, and that's just by virtue of their addition. It's not even about swapping them for something else, slide. And I want to emphasize the tremendous body of literature that substantiates this. There's like 58 randomized controlled trials for oats, 26 for beans, 61 for nuts. It's so impressive how much research has demonstrated this, slide. If you do a head-to-head comparison, there was one study where they fed people a cup of almonds every day and showed that it lowered LDL cholesterol as much as low dose atorvastatin, slide. That is a lot of almonds. I'm not necessarily recommending this. If you count it out, it's a lot, slide. But we do know that the portfolio diet, which combines multiple cholesterol-lowering foods, can have this effect, slide. Obligatory picture of me with the inventor of the portfolio diet, slide. And there's a nice handout that you can give your patients to illustrate this diet for them, slide. I like to give my patients information about all of the foods that, when added to the diet, can lower their cholesterol level. And I just say, the more of these foods you eat, the lower your cholesterol level will be. And it gives them lots of options that they can adapt to their preferred dietary pattern, slide. So in conclusion, what's the secret to healthy eating, slide? Well, in 500 BC, Plato spoke about nutrition, and he said a healthy diet consists of barley, wheat, legumes, fruit, fish, and olive oil. And he said treats to be consumed in moderation are meat, confectionaries, and wine. 2,000 years later, nothing's really changed. Healthy eating is about balance, slide. And that is really what our food guide illustrates and recommends, slide. So that's where I'll leave things. And thank you so much for listening. And I'm happy to answer questions.
Great. Thanks so much, Mary, for really bringing to light a few things that I think we don't necessarily know about or have been taught about as much. So great to have some fresh ideas for how to counsel our patients. And I know my family's been laughing at me since I saw your talk a year ago. I'm always eating my salad first when I have my meals. Anyway, I think I'm going to start. There's a lot of questions around flaxseed. Specifically starting with like what type of flax seeds and do they need to be ground or not in order to have their impact on the blood pressure?
Great question. So in terms of like, there's like the golden flax or the other dark brown flax. My understanding is it's the omega-3 fatty acids. So the type of flaxseed shouldn't matter. The flax seeds must be ground or milled. And the reason is because the omega-3s are on the inside and there's that hard outer seed coat, which we can't digest. So if we eat them whole, they're still healthy because they're fiber, but you're not going to get those omega-3s in, or you're not going to get the full benefit. So ground or milled is going to be the best option. And to prevent those omega-3s from getting oxidized, you want to store your flax seeds in the fridge or the freezer. That way you're going to actually get the benefit and they're not going to become rancid and also not taste well.
Great, thanks very much. And on the note of flaxseed, and I think you just answered this because you were talking about it being the phospholipid bilayer, but is it, the question was, is the reason that flaxseed is more effective than omega-3 supplements because the flaxseed has fiber?
I think so.
Yeah.
Yeah, I sometimes say that flax seeds are like nature's multivitamin. There are so many nutrients in that seed that definitely there's more going on there than just the omega-3 fatty acids.
Great. And you did answer this in terms of omega-3 supplements, that they aren't shown to be helpful. So are there any benefits to taking an omega-3 supplement, or do you generally just not recommend them?
It's a great question. It's one that I spend a lot of time thinking about, and there are a few clinical contexts where I think they could be recommended, although with the caveat that it's exceptionally hard to verify if your omega-3 fatty acid is going to give you that benefit just because of the lack of controls in the marketplace. So that's what we're up against. But despite that, there are randomized controlled trials using commercial products that do demonstrate beneficial effects. So some key clinical areas where I utilize omega-3s is for people who suffer from migraines. There's good data there, and it takes 3 months to see the benefit because you have to turn over your cells to see the benefit. There is some data for patients with osteoarthritis. So it's worth a try. Again, it takes 3 months to see the benefit, but it might be worth that because we don't have a lot of options for those patients. In pregnancy, omega-3 fatty acids can be very helpful, particularly in preventing preterm birth. This is something I have guides about and have done research on in the past. There's a Cochrane review demonstrating this. With triglycerides, it's a little controversial, especially even like Vascepa, like our pharmaceutical version of omega-3s. And then finally, there are some randomized controlled trials for depression and anxiety. Personally, I don't use that too often clinically, but that data does exist. Now, times when they're not beneficial is outside of lowering triglycerides, overall cardiovascular disease risk is not improved. And the other area where a lot of people want to take them is with respect to dementia and memory. And also, there is not sufficient data to recommend them in that context.
Great. Thank you for such a thorough response to that question. Now, I'm going to throw one at you, which is not actually something that you specifically talked about, but has got a lot of upvotes. So I'm gonna get your thoughts on it. What do you think of anti-inflammatory diets, avoiding gluten, nightshade, vegetables, lectins, etc.? I've seen patients have great results, even though industry has been promoting against it. We still have a lot of disease despite, quotes, whole food diets. So I guess
Okay.
thoughts on
So
anti-inflammatory.
yeah, so the term anti-inflammatory diet, of course, is defined. There's many different versions of what an anti-inflammatory diet is. So there are certain versions of anti-inflammatory diets, particularly those that are like very high in fruits and vegetables and high in fiber, that I think 100%, I think inflammation is the driver, and it's a player in so many of the diseases that we're dealing with every day. So I do think we need to be looking at diet and the effects of the inflammatory effects that it has and dialing that down where possible. As for what are the drivers of that inflammation, I do think there are individual people who are sensitive to certain things that we don't have the literature to understand fully right now. So when it comes to, I think did you mention gluten? Like, we know that non-celiac gluten sensitivity exists. We can't measure it, but some people are going to have effects from that nutrient, even though we don't have a objective and rigorous way of diagnosing them with that. The nightshade thing is interesting because there's just no data, right? There's no data to substantiate it. But these patients come in and they claim that this has changed everything for them. So when a patient comes in and says that, I say, great. Do I automatically recommend it to other people? I typically don't see myself doing that, usually because there's other bigger issues that I think are more important to address first, as opposed to just taking out those foods. Like, for example, usually there's still a lot of sugar in the diet, or there's not enough fruits and vegetables, and I'd rather tackle those things before I go after those elimination. But it really depends on the patient. I think that there's so much that we don't understand, and we have to kind of be humble about that and be willing to experiment with the patients who are interested in experimenting with different things.
Great. Thanks so much, Mary. I'm going to just mention that we're going to do our last couple of slides because I see it's 8:57. And then we'll come back and answer some more questions because there are a bunch there. So I'll perhaps get you to pull up the slides and I think turn things over to Jobin.
Thanks so much. Just wait for the slides. I want to thank everybody, and thanks, Dr. Sco. I don't know if you've seen the chat yet. The chat's just blowing up with thank yous to you and how amazing the presentation was. If we could just go back 2 slides, please. Thank you. And it's just a quick reminder to everybody that we have the other community practices between Practicing Well. Our health equity community of practice has had its second session. We have another one in November 27th, as well as the ones you see here from our mental health. And a reminder about the Peer Connect mentorship. Next slide. And a big invitation to everybody here to please join us as we celebrate this year's award recipients for their outstanding contributions to family medicine. And that's on November 19th. It will be virtual. And we're looking forward to seeing you there. Eleanor, back to you.
Great. Thanks very much, Jobin. Next slide, please. So just wanted to put out that we are running within the DFCM a first 5 years community of practice. Our next session is on October 21st from 7 to 8 p.m. And we have another one in November. If you are in your first 5 years of practice, please feel free to sign up. It is free of charge, and we'd love to see you there. Next slide, please. Just a reminder also that this is a series and our other sessions are posted online, so feel free to check them out. Next slide, please. And our upcoming session, October 31st, Halloween. So hope to see you then. Next slide, please. And just a reminder again that this is Main Pro accredited. Last slide. That is all the slides. Wonderful. Thanks very much. We'll turn back to some questions with Mary. And actually, the first thing I was just trying to do here was post in the chat there the prescription handouts that you sometimes use, because I think a couple of people have asked about them. So just I've posted that there. Another question that's come up is just around food processing. And can you comment on like the different additives and glyphosate and preservatives and their role in creating inflammation or disease in the body? I'm sure this is a question you must get asked about.
This is a good question. To be honest, it's not one of the things that I'm discussing on a regular basis with patients. I do think that these issues are these are big issues. But I do think that these issues are like secondary to like the overall choice of food. So yes, all the additives, the pesticides, the glyphosate, all of those things are problematic in our food supply. But often the biggest changes that need to be made that will have the largest clinical benefit for our patients are more basic than that. So I do think those things are a problem, but I don't have a solution for them. And when it comes to like organic and things like that, again, it really depends on that individual person and what's going to fit with their lifestyle. But even if they can't afford organic, it's the most important thing is that they're eating fruits and vegetables. That's kind of how I see it.
Great, thanks very much for that. Question about how to increase HDL. You talked about lowering LDL. Any thoughts on that?
I love that someone asked this question. So first of all, the important thing to remember is that the data for the effect of HDL and overall risk for cardiovascular disease is not as strong as other risk factors. So it has kind of come out of the limelight in recent years because we know that even increasing it like doesn't change outcomes as much as we originally expected. However, as someone who eats a tremendous amount of olive oil, I can tell you I have a low HDL despite the 4-liter tin of olive oil on my kitchen counter. So I'm a little bit perplexed by this, and I find that so many of my patients come in and they're very disappointed by their low HDLs, and I'm not 100% sure what else to recommend to them because they're eating the olive oil, they're eating the avocados, and it's still not going up. So I have not figured this one out myself, but it's also not the most important risk factor. At least that's what the studies are suggesting.
Great, thanks very much, Mary. Just a question around protein supplements. Do you recommend them? Are we all deficient in protein? I certainly know those of a certain age category are being told that we need to eat a lot more protein.
Absolutely. I think that protein is important, but I also think the source of the protein is very important. When increasing protein intakes, always want to encourage my patients to eat plant protein sources because number one, plant protein like beans, nuts, these are like the healthiest foods that exist. So I do think we need to encourage patients to eat protein because even as we showed, like you need that balance. You need the protein at every meal, the carbs and the vegetables. So you can't leave any group out. That being said, when it comes to processed foods, protein powders are a processed food. So a processed food is never going to be your top choice. You always want to eat real whole foods. So I rarely recommend protein supplements to patients. I think that it's better to aim to increase your protein from plant-based sources. And that's probably going to be the best thing that you can do to impact your overall health. There would be individual scenarios where a supplement might be helpful. But as much as possible, I encourage plant protein.
Perfect. Tagging on to that, actually, because you're talking about plant protein, somebody had asked how much red meat is okay.
I know it's a tricky question and it's going to vary depending on the person. I would tailor it based on what numbers look like. Again, it's like do the experiment. Maybe say I'm going to eat red meat 2 to 3 times a week. Do that for, your cholesterol is a reflection of the last 2 weeks when we measure LDL. So you could do that for a month and measure LDL and see how well your LDL holds up with respect to that. And I think that's the best way to understand that because it's really going to depend on the person. The other thing is the more important question is what is the context within which that red meat is being eaten? If you're eating that red meat with lots of vegetables, with lots of fiber, it's actually going to affect your health differently because we know the fiber and the vegetables are actually going to bind some of the carcinogens and prevent their absorption. So context also matters. It's not just a matter of how often, it's in what context.
Great, thanks very much. I'm actually, I always thought I was taught to check cholesterol like 3 months later, but you're saying your LDL numbers would change within two weeks?
That's what we've seen in some of the trials with the portfolio diet is you actually reach your maximum benefit 2 weeks later and it just stays there. It depends on how aggressively and how quickly you change things.
Okay, great. Actually, just regarding the portfolio diet, there's a comment here. Excellent presentation, Dr. Sco. Lipids portfolio diet. What are your thoughts on the new phytosterol product, Cardio Smile?
Oh,
You're familiar with it?
I actually haven't seen this yet. For a long time, the phytosterols were coming in like a margarine, but then I think that got taken off the market because it wasn't that popular. So I can't say I haven't seen this new product yet.
No problem. Question here around intermittent fasting. Dr. Sko, does intermittent fasting or what you call time-restricted eating affect other metabolic indices such as weight, blood pressure, cholesterol?
Absolutely. And the important thing to realize is that intermittent fasting, time restricted eating means so many different things. In some cases, it means you're fasting 2 days a week and eating regularly 5 days a week. In some cases, the eating window is 6 hours or 8 hours or 10 hours. There are so many different protocols. And another thing that I think is really important is when the fasting is taking place. Most people, because it's just easier, want to skip breakfast, skip lunch, and then make their eating window late at night, which is not in congruence with our circadian rhythm. So the protocol I showed was specifically eating between 8 a.m. and 6 p.m., which I think is also crucial. So yes, many metabolic factors are positively influenced by time restriction or intermittent fasting, but it also depends on the protocol.
Great, thanks very much. Actually, on the note of intermittent fasting, does prolonged fasting increase your risk of gallstones?
Oh, that's really interesting. I mean, we know that anybody who loses weight quickly is going to be at increased risk for gallstones. I personally haven't seen literature specifically saying that the fasting does that. That might exist, and I just haven't looked into that deeply enough. But it might be indirectly through the weight that somebody would lose.
Okay. Um, on a slightly unrelated note, but people are obviously very interested in your nutrition training. They're wondering how you got into this field and what courses you took, or any suggestions you have, I guess, for increasing our own knowledge.
Okay, sure. So sometimes when I give the full long version of this presentation, I start with a slide that shows that my interest in nutrition started with a science fair project when I was 16. And I actually studied nutrition before I went into medical school. So I did my undergraduate degree in nutrition science, and then I went to graduate school and did a PhD in nutrition science. Then I wanted to take and I wanted to apply it practically. So that's why I went into medicine. So I really started off only in the nutrition field, and then I wanted to sort of bring that knowledge out of the nutrition world into other worlds, and that's what led me to medicine. So in terms of, obviously lots of years went into this, but as for like how a family doctor can learn more, what is the best source? I don't, it's tricky because I'm not necessarily looking at nutrition CMEs all the time. So I don't have a perfect answer. But I will say, like, the guides on my website summarize things really nicely. There's a longer version of this lecture and other lectures that I share online. So this is like a full out 1 hour of this topic, among others. So I would say, like, check those things out. And I'm trying to think, I need to make a recommended reading list. I will work on that.
Great, thanks very much. That's very helpful. And yeah, you certainly have so much background in nutrition. Couple of other questions. Back to just the protein I think you had mentioned you didn't feel that generally protein supplements in powder form were a good idea or necessarily recommended. But there is a question here around, is creatine a good supplement if you were to be taking one, I guess?
Yeah, and I'm gonna say I don't like in my clinical practice, it's not one that I'm recommending. In a certain context for a certain individual, maybe, but it's going to be based on that individual context. I don't really have many supplements that across the board I'm recommending on a daily basis.
Excellent, thanks for that. Just a quick question back to flax seeds, whether the benefits are still preserved if it's baked or cooked. I guess yeah, depends on
This
the
is
grinding.
something that's very interesting because heat can oxidize an omega-3 particle. Despite that, the studies show that the benefits are preserved even with cooking, which is interesting. That's what the studies show.
Great, good to know it can be added. Can you talk about glycemic index versus glycemic load?
Sure. So glycemic index uses a standardized amount of that carbohydrate. So it's always comparing the exact same portion of each food in terms of like grams. Glycemic load takes into consideration the fact that if you eat a larger portion of carbohydrates, you're going to get a larger spike in blood sugar, even if it's a low glycemic index food. So the reality is, you could eat something low glycemic index like parboiled rice. But if you eat a huge portion of parboiled rice, the impact on blood sugar levels can be equivalent to eating a smaller amount of white rice. So it takes into consideration portion size and how portion size is also driving blood sugar levels.
Great, thanks very much for that. Just in terms of fruit, doctors go, does fruit, the sugar in it, contribute to diabetes, hypertension, triglycerides increase? How do we, I think you talked about some of the slides that you have that demonstrate the different sugar contents of fruit, but maybe just commenting on that.
Yeah, so the answer is it can. It can. Like if someone has diabetes and they're eating a large amount of fruit every day, that's still sugar that's going to raise their blood sugar level. But we can't really talk about fruit as being one thing because different fruits are so different. Like if they're eating apples, they're not going to have that effect in the same way as if they're eating pineapple all day long. So that's where that glycemic index fruit guide comes in handy because it's showing patients that different fruits are going to have different potentials for raising your blood sugar, and that's different potential for worsening your diabetes or whatever it may be. So the answer is like it depends. It depends on what fruit you're eating, and more importantly, it depends on how frequently and how much you're eating.
Great, thanks very much for that. I think we could have you here all day, Mary. So I'm going to ask a few more questions and let everybody get back to their clinics. But we'll finish up with a few last ones. Is there any evidence for the use of omega-3 in ADHD? Are you familiar with that?
You know, I haven't looked at that literature recently. The last time I looked at it, it's one of those things I think it's more observational, or it's like very, very small trials with modest effect sizes, if I remember correctly. But again, there are so many factors. Like there might be some children for whom that is helpful, and we have to design studies to understand like who's our target group and such. So it's one of those things where I wouldn't say that across the board I'm recommending it, but I wouldn't say that we know, because maybe we just need to study it more.
Right, excellent. Is there evidence to support taking vitamin K along with vitamin D to aid in absorption?
You know, I know everybody's taking that. Let me speak about vitamin D absorption for a second. Vitamin D absorption requires fat. So when patients are taking vitamin D, they should be eating it with their fattiest or most fat-rich meal of the day, which I say is usually your largest meal of the day. So that's the most important factor. You lose about 30% of the vitamin D that you're taking if you take it on an empty stomach without any fat. So that's the most important factor for vitamin D absorption. There is this whole thing with vitamin K. I actually personally need to look into that more. It's not something that I've traditionally been tuned into, but I think the bigger issue is eating your vitamin D in the context of your most fat-rich meal.
Great, that's super helpful. Take that to practice. Take that back to practice. Another question just around fats generally. So you were mentioning HDL doesn't seem to be affected too much by diet, and just wondering whether exercise has more of an impact on HDL than diet.
I haven't looked at that data specifically. I wouldn't be surprised if it does influence it, although it's not working for me personally. But I mean, I think it probably has a positive effect. I don't know the magnitude of the degree of change though.
Right, excellent. And does flaxseed have any impact on triglycerides, or is there anything that you can do to help with triglycerides?
Interesting. You know what? I think that it would, based on the fact that it's an omega-3 fatty acid, and we know that omega-3 fatty acids can improve triglyceride levels. In general, the things I recommend for patients with high triglycerides are to eat monounsaturated fats. So that's the type of fat you get from olive oil and avocado oil. We know that that helps with triglycerides. The other thing that helps with triglycerides is actually eating low glycemic index foods and avoiding blood sugar spikes. So that same education that you would give someone with diabetes is going to be relevant for that person with high triglycerides as well. And the other thing about triglycerides is, even though, yes, they're a risk factor that we're measuring, again, they're not the strongest risk factor for cardiovascular risk and events. So it's one that I don't often focus on as much because I want to influence other things that are more stronger predictors.
Great, thanks very much for that, Mary. So I'm going to do 3 last questions, and then we'll stop for today. And maybe we'll just have to have you back with this number of questions. So first of all, does roasting almonds change the nutritional value in terms of lowering the blood pressure? It's one question.
I don't think roasting matters. I mean, you got to make sure they're not roasted with salt. That's going to be like the big thing there. But I don't think roasting would change it. And when it comes to the almonds, it really is the plant sterols that they contain. So they contain molecules that look like cholesterol. So when you eat those almonds, you're going to have that biomimicry that your body is going to block the absorption of the cholesterol because this other particle is going to take its spot on the receptor.
Great. And any diet that can be advised for isolated diastolic hypertension?
Oh, that's a great question. I don't have an answer for that. Maybe there's something out there. I haven't personally looked into it though.
Right. And then just one last question. If someone has a baseline low blood pressure, what happens when they eat a diet high in potassium? I guess the question is, could it lower their blood pressure too much? They're
That's
already
a
low.
That's a really good question. I haven't personally encountered that or worked on that. I want to believe that like the regulatory mechanisms work, you know, so even if you put a little more potassium in, the sensors are going to do, the RAS system is going to do what it needs to do. So I wouldn't be like scared of adding that potassium from dietary sources because I feel like there are more than just, there's lots of checkpoints in blood pressure regulation.
Right. And I lied, I'm going to ask you one last one. Can you comment on glycemic index if higher carb foods are cooled or frozen prior to consumption? Does that impact at all?
It does. It does. Okay, so the perfect example is a baked potato. A baked potato that's eaten when it's hot out of the oven actually has a higher glycemic index than eating that baked potato after it's cooled down. So for example, eating, potatoes in the form of potato salad, which would be chilled or cooled. And that is because when you heat the starch molecules in the potato, the starch molecules become more bioavailable. So we digest it more quickly and it spikes our blood sugar more quickly. When it cools down, those starch molecules like gelatinize in a way that's such that it takes our body more effort to digest it. And that's why it has a lower glycemic index when you eat it cooled. Good question.
Great. And we're going to finish on that one. There was all sorts of please bring Dr. Sko back, and thank you very much for your excellent presentation. I also want to thank Dr. Evans, who's not with us anymore, and also Dr. Dan Wachowski for our talk today and answering our questions as per usual. Hope everyone has a wonderful weekend, and see you on the 31st.